Welcome back, everyone. Let's begin with figure 54, which presents a practical approach to the triage and management of precordial effusion. This flowchart helps determine which patients require urgent intervention and which can be managed conservatively. The first question to ask is whether the patient has cardiac tamponade or whether there is a suspicion of bacterial or malignant cause of the effusion. If the answer is yes, the patient requires urgent pericardiocentesis, both to relieve the pressure around the heart and to obtain fluid for diagnostic analysis to identify the underlying cause. If the answer is no, the next step is to assess inflammatory markers such as ESR and C-reactive protein. If the inflammatory markers are elevated, the effusion is likely inflammatory, often due to acute pericarditis. In these patients, we initiate empiric anti-inflammatory therapy, treating the patient as acute pericarditis with NSAIDs, colchicine, and addressing any underlying cause. If inflammatory markers are not elevated, we then think whether there is a known associated disease such as autoimmune disease, chronic kidney disease, hypothyroidism, or malignancy. If there is a known disease explaining the effusion, the pericardial effusion is considered secondary to that condition, and management focuses on treating the underlying disease. If there is no associated disease, the next decision depends on the size of the effusion. If the effusion is less than 200 millimeters, patients are generally managed with clinical follow-up and serial echocardiography. However, if the effusion is large, greater than 20 millimeters, and especially if it persists for more than 3 months, clinicians should consider precardiocentesis and drainage, even if tamponade has not yet developed, because chronic large effusions carry an increased risk of future tamponade. This algorithm emphasizes that treatment depends not only on the size of the effusion, but also on the clinical presentation, inflammatory activity, and underlying etiology. Cardiac tamponade. Now let's discuss one of the most important emergencies involving the pericardium, cardiac tamponade. Definition. Cardiac tamponade is the accumulation of fluid, blood, pus, clots, or even gas within the pericardial sac, resulting in increased pressure around the heart. This pressure prevents normal cardiac filling during diastole and eventually leads to life-threatening circulation collapse. Importantly, tamponade may develop rapidly, such as after trauma or cardiac rupture, or slowly as fluid gradually accumulates. Etiology. There are many causes of cardiac tamponade. The most common mechanism is rapid accumulation of pericardial fluid, making tamponade one of the major complications of acute pericardial effusion. Common causes include acute pericarditis, tuberculosis, iatrogenic injury following cardiac procedures, chest trauma, and malignancy. Less common causes include autoimmune connective tissue disease such as systemic lupus erythematosus, rheumatoid arthritis, and scleroderma. Radiation therapy, post-myocardial infarction, free wall rupture, uremia, aortic dissection, bacterial infection, and pneumopericardium. Remember that cardiac tamponade is clinical diagnosis. Echocardiography confirms the diagnosis, but treatment should never be delayed in unstable patients. Pathophysiology. Understanding the pathophysiology makes the clinical findings much easier to remember. As pressure inside the precordial sac rises, first venous return leads to reduced ventricular filling during diastole. Poor ventricular filling decreases stroke volume and cardiac output. The result is systemic hypotension while blood backs up into the venous circulation, producing venous congestion. Therefore, tamponade simultaneously causes low cardiac output and elevated venous pressure. Signs and symptoms. The clinical presentation reflects impaired cardiac filling. Patients often present with the tachycardia, hypotension, elevated jugular venous pressure, tachypnea, dyspnea, signs of shock, and muffled heart sounds. A particular important physical finding is pulsus paradoxus, defined as an inspiratory fall in systolic blood pressure of more than 10 millimeters of mercury during quiet breathing. When examining the neck veins, remember that tamponade shows loss of the Y descent while the X descent remains preserved. This occurs because ventricular filling is severely restricted. As venous congestion worsens, patients may develop hepatomegaly, hepatic congestion, and peripheral edema. The severity of symptoms depends not simply on the amount of fluid, but on several factors. The speed of fluid accumulation, total volume of precordial fluid, compliance of precordium, cardiac filling pressures, and chamber compliance. A small amount of rapid accumulating blood can produce tamponade, whereas very large chronic effusions may initially be tolerated. Classic clinical findings. 2 classic bedside mnemonics are highlighted on this page. Classic quartet of tamponade. The 4 hallmark findings are hypotension, elevated jugular venous pressure, tachycardia, and pulsus paradoxus. Beck's triad. Beck's triad consists of hypotension, elevated jugular venous, and muffled heart sounds. While Beck's triad is classically taught, not all 3 findings are present in every patient, especially in early tamponade. Investigations. Several investigations help confirm the diagnosis. Electrocardiogram. The ECG may show low voltage QRS complexes, electrical alternance, whereas the QRS amplitude varies beat to beat because the heart swings within a large effusion. This finding is highly suggestive of a large precordial effusion. Chest X-ray. Chest X-ray may reveal an enlarged globular cardiac cell health, particularly when the effusion develops slowly. CT or MRI. CT and MRI are used less frequently and are usually reserved for situations where echocardiography is technically difficult or unavailable. Echocardiography. Echocardiography is the diagnostic test of choice. It evaluates presence and size of the effusion, location of fluid, hemodynamic impacts, right atrial collapse, right ventricular diastolic collapse, and swinging motion of the heart. It also guides echo-assisted precardiocentesis, improving procedural safety. Cardiac catheterization. Cardiac catheterization is rarely required today, but may demonstrate equalization of diastolic pressure in all cardiac chambers. Treatment. Cardiac tamponade is a medical emergency requiring immediate treatment. The definitive treatment is urgent precardiocentesis, preferably under echocardiographic or fluoroscopic guidance. In some situations, surgical drainage or pericardial window is preferred, particularly in patients with purulent pericarditis, recurrent effusions, or bleeding in the pericardial space. Supportive management is equally important. Avoid diuretics and vasodilators because this reduces venous return and worsens cardiac output in an already underfilled heart. Care should also be taken with positive pressure mechanical ventilation, as it can further reduce venous return and precipitate cardiovascular collapse. If the patient is hypotensive, intravenous fluid may temporarily increase preload and improve cardiac output while preparing for definitive drainage. Finally, always identify and treat the underlying cause, whether infection, malignancy, autoimmune disease, trauma, or uremia. The key message is simple. Cardiac tamponade is a life-threatening emergency caused by impaired ventricular filling. Rapid recognition, prompt echocardiographic confirmation, and urgent precordial drainage are life-saving interventions. Let's move to figure 55. This figure demonstrates how increasingly precordial fluid affects cardiac filling and how precardiocentesis restores normal hemodynamics. Panel A, normal heart, no pathology. The first image represents the normal heart. Normally, the heart is enclosed within the precordium, which contains a small amount of lubricating fluid, approximately 15 to 50 milliliters. This fluid reduces friction during cardiac contraction. The interventricular septum remains in its normal position and both ventricles expand freely during diastole. Venous return is normal, ventricular filling is unrestricted, and cardiac output is maintained. Panel B, cardiac tamponade during inspiration. Now observe the second panel. Here, excess fluid accumulates rapidly within the precordial sac, producing a precordial effusion. Because the fibrous precordium cannot stretch quickly, the rising intraprecordial pressure compresses the cardiac chambers, particularly the thinner-walled right atrium and right ventricle. During inspiration, venous return to the right heart normally increases. However, the tamponade prevents the right ventricle from expanding outward. Instead, the interventricular septum shifts toward the left ventricle. This reduces left ventricular filling. As a result, stroke volume and systolic blood pressure falls during inspiration. This exaggerated inspiratory decrease in systolic blood pressure is known as pulsus paradoxus, one of the classic signs of cardiac tamponade. Clinically, patients develop hypotension, tachycardia, elevated jugular venous pressure, and dyspnea. Panel C, cardiac tamponade during expiration. During expiration, venous return to the right heart decreases slightly because less blood enters the right ventricle. Compression of the left ventricle is reduced. Consequently, left ventricular filling improves, cardiac output temporarily increases, blood pressure partially recovers. Although there's some improvement, the underlying problem remains because the elevated precordial pressure continues to impair overall cardiac filling. Panel D, precardiocentesis. The final panel demonstrates the definitive emergency treatment. A needle is inserted into the precordial space to remove excessive precordial fluid. As fluid is aspirated, intraprecordial pressure falls. Ventricular wall collapse, resolve. The ventricles expand normally during diastole. Venous return improves. Stroke volume increases. Cardiac output returns toward normal, and blood pressure stabilizes rapidly. Precardiocentesis is life-saving emergency procedure in patients with a hemodynamically significant cardiac tamponade. Now let's move to the next topic, constrictive pericarditis. Unlike tamponade, which results from fluid accumulation, constrictive pericarditis results from a rigid, scarred precordium that permanently restricts ventricular filling. Although both diseases impair diastolic filling, their mechanisms are entirely different. Constrictive pericarditis is defined as the loss of normal precordial elasticity caused by chronic inflammation and granulation tissue formation. Over time, the pericardium becomes thickened, fibrotic, and sometimes calcified. The rigid pericardium prevents normal ventricular expansion during diastole, leading to restricted ventricular filling. Etiology. Most cases develop after chronic inflammation of the pericardium. Important causes include chronic or recurrent pericarditis, idiopathic diseases, which remain the most common cause in developed countries, viral pericarditis, bacterial or purulent pericarditis, tuberculous pericarditis, which remains an important cause worldwide, previous mediastinal radiation therapy, cardiac surgery, uremia associated with chronic kidney disease, myocardial infarction, and connective tissue or collagen vascular disease. Essentially, any condition causing persistent pericardial inflammation can eventually lead to constrictive pericarditis, although the likelihood depends on the underlying cause. Pathophysiology. The hallmark abnormality is a rigid fibrotic pericardium. During diastole, the ventricles begin to fill normally. Very quickly, the stiff pericardium reaches its limit. Further ventricular expansion abruptly stops. Diastolic filling becomes severely restricted. As ventricular filling decreases, venous return backs up into the systemic circulation, central venous pressure rises, right side heart failure develops despite relatively preserved myocardial contractility. Patients therefore develop signs of symptoms of venous congestions, including elevated jugular venous pressure, peripheral edema, hepatomegaly, ascites, and fatigue, exercise intolerance due to reduced cardiac output. Most patients initially have preserved systolic function since the myocardial itself is usually normal. However, in advanced diseases, chronic inflammation may extend into myocardium, producing fibrosis of myocardial atrophy, eventually causing systolic dysfunction as well. To conclude this page, remember these high-yield distinctions. Cardiac tamponade is caused by increased pericardial fluid, producing acute external compression of the heart. It is characterized by hypotension, elevated jugular venous pressure, muffled heart sound, and pulsus paradoxus, and requires urgent pericardiocentesis. Constrictive pericarditis is caused by a thickened, fibrotic, non-compliant pericardium that chronically limits ventricular filling. Patients present predominantly with signs of right-sided heart failure with systolic function is often present until late in the disease. Understanding the difference between these two conditions is essential because tamponade is an acute medical emergency requiring immediate drainage, whereas constrictive pericarditis is a chronic mechanical disorder that often requires surgical pericardiectomy for definitive treatment. Now we'll discuss constrictive pericarditis in detail, an important chronic pericardial disease in which pericardium becomes thickened, as we discussed before in the last page. It becomes thickened, fibrotic, and sometimes calcified. This rigid pericardium restricts ventricular filling during diastole, leading predominantly to right-sided heart failure, while systolic function is often preserved initially. Understanding its clinical presentation, investigations, treatment, and differentiation from cardiac tamponade is essential for the MCCQE examination. Sign and symptoms. So, like before, we're going to repeat again. Patients commonly present with dyspnea, fatigue, and palpitations due to reduced cardiac output. Some patients also complain of abdominal pain, which results from hepatic congestion. Because constrictive pericarditis limits ventricular filling, it frequently mimics chronic right-sided heart failure. Consequently, patients develop venous congestion, peripheral edema, ascites, hepatosplenomegaly, and pleural effusion. One of the hallmark examination findings is an elevated jugular venous pressure, or JVP. A classic feature is Kussmaul's sign, which is a paradoxical increase in JVP during inspiration. Normally, JVP falls with the inspiration, but in constrictive pericarditis, the rigid pericardium prevents increased venous return from entering the right ventricle, causing the JVP to rise instead. Another characteristic finding is Friedrich's sign, which is a prominent and rapid Y descent on jugular venous pulse. This reflects rapid early ventricular filling followed by abrupt cessation because of the stiff pericardium suddenly limits expansion. Unlike cardiac tamponade, blood pressure is often normal and pulsus paradoxus is usually absent. On cardiac auscultation, an early diastolic sound known as the precordial knock may be heard. This occurs slightly early than the third heart sound and represents sudden cessation of ventricular filling when the non-compliant precordium is reached. Causes of pulsus paradoxus. On the right side of the page is a helpful differential diagnosis of pulsus paradoxus. Remember that pulsus paradoxus is not a typical feature of constrictive pericarditis. Important causes include most causes of right ventricular failure except restrictive cardiomyopathy, severe obstructive pulmonary disease, especially asthma, pneumothorax, and pulmonary embolism, cardiogenic shock, cardiac tamponade, and eventually effusive constrictive pericarditis. Among this cardiac tamponade is the classic board examination association with pulsus paradoxus. Investigations. Let's move on to the investigations. Electrocardiogram, the ECG findings are generally non-specific and may include low voltage QRS complexes, flattened T waves, and occasionally atrial fibrillation. These findings reflect chronic pericardial disease rather than a specific diagnostic pattern. Chest X-ray. The chest radiography may demonstrate pericardial calcification, which is highly suggestive of constrictive pericarditis and associated pleural effusion. Echocardiography, or CT, and cardiac MRI. These imaging modalities evaluate pericardial thickening, pericardial calcification, characteristics, Doppler findings demonstrating impaired ventricular filling. An important examination pearl is the cardiac MRI. Should be avoided in hemodynamically unstable patients since it's time-consuming. Cardiac catheterization. If non-invasive imaging is inconclusive, cardiac catheterization becomes the gold standard. It demonstrates equalization of end diastole pressures in all cardiac chambers, hemodynamic evidence of impaired ventricular filling caused by constriction. The diagnosis is established when the patient has symptoms of right-sided heart failure, evidence of impaired diastolic filling, and confirmation of constriction by one or more imaging modalities or cardiac catheterization. One very important point is that up to 20% of patients may have normal precordial thickness, yet still have constrictive physiology. Therefore, normal imaging does not completely exclude constrictive pericarditis, and these patients may still benefit from surgery. Treatment. Treatment depends on whether the disease is chronic or potentially reversible. Surgical treatment. The definitive treatment for chronic constrictive pericarditis is precardiectomy, which involves surgical removal of the diseased pericardium. This is considered the mainstay of therapy and offers the best chance for symptoms relief. Medical therapy. Medical treatment has three main roles. First, treat the underlying cause whenever possible, such as tuberculosis. Second, patients with transient constriction or active inflammatory pericarditis may improve with an anti-inflammatory medications, avoiding surgery altogether. Third, for patients who are poor surgical candidates, supportive therapy focuses on reducing congestion through diuretics and salt restriction. These measures improve symptoms but do not cure the disease. Prognosis. The prognosis depends largely on the underlying cause. Patients with the idiopathic or infectious constrictive pericarditis generally have the best outcomes after surgery. Patients whose disease results from prior chest radiation have the poorest prognosis because of associated myocardial and mediastinal damage. Without effective treatment, progressive heart failure may eventually lead to death. Table 19. Differentiating constrictive pericarditis from cardiac tamponade. This table is extremely high yield for examinations because these two conditions share elevated jugular venous pressure but have several distinguishing features. First, the JVP waveform. In constrictive pericarditis, there is a prominent Y descent followed by the X descent. The rapid Y descent reflects brisk early ventricular filling that abruptly stops because of the rigid pericardium. In cardiac tamponade, the X descent is preserved but the Y descent is absent or blunted, since fluid under pressure prevents ventricular filling throughout diastole. Second, Kussmaul signs. Presence in constrictive pericarditis and absent in the cardiac tamponade. Third, pulsus paradoxus. Uncommon in constrictive pericarditis, classically present in cardiac tamponade. Fourth, precordial knock. Present in constrictive pericarditis, absent in cardiac tamponade. Finally, blood pressure. Hypotension is variable in constrictive pericarditis but is typically severe in cardiac tamponade, reflecting impaired cardiac output. To conclude this page, constrictive pericarditis is caused by a rigid fibrotic pericardium that restricts diastolic filling. It presents predominantly with right-sided heart failure, elevated JVP, Kussmaul sign, Friedrich signs, and precordial knock. Imaging shows precordial thickening or calcification, while cardiac catheterization demonstrates equalization of diastole pressures. Precardiectomy is the definitive treatment for chronic disease. Differentiate constrictive pericarditis from cardiac tamponade by remembering Kussmaul signs and precordial knock for constrictive pericarditis. Pulsus paradoxus, absent Y descent, and severe hypotension favors cardiac tamponade. These distinctions are frequently tested on MCC-QE and are among the highest yield concepts in precordial disease. Let's follow the blood flow through the circuit as shown in figure 56. During cardiac surgery, the heart often needs to be stopped to provide a stable surgical field. This is achieved by placing the patient on a cardiopulmonary bypass machine, which performs two essential functions. It pumps blood throughout the body, and it oxygenates and removes carbon dioxide from the blood, replacing the function of the lungs. Meanwhile, the heart is protected using cardioplegia, allowing safe surgical repair. Step 1. Venous drainage. The circuit begins with the venous blood leaving the patient. Large venous cannulas are inserted into the right atrium or vena cava, allowing deoxygenated blood to drain into the bypass machine by gravity or assisted drainage. A venous clamp regulates the amount of blood entering the circuit. The blood then enters venous reservoir, which serves several important purposes. It stores circulating blood, it allows air bubbles to escape, it provides a reserve volume for the perfusionist, and A level sensor continuously monitors blood volume to prevent the reservoir from emptying, which could introduce air into the circulation. Step 2. Oxygenation. Blood next passes into the membrane oxygenator, often called the artificial lung. Here, two critical processes occur. 1. Oxygen is added to the blood. 2. Carbon dioxide is removed. Fresh gas enters the oxygenator through a gas blender, which mixes oxygen with air to achieve the desired oxygen concentration. The gas flow is measured by a gas flow meter, ensuring adequate oxygen delivery. If anesthesia needs to be maintained through the bypass circuit, an anesthetic vaporizer delivers volatile anesthetic gases directly into the oxygenator. Step 3. Temperature control. The oxygenator contains a heat exchanger connected to a cooler heater water source. This system allows the perfusionist to precisely control the patient's temperature. Cooling the patient decreases metabolic demand and protects organs during prolonged surgery. Once the repair is complete, the patient is gradually rewarmed before separation from bypass. Stage 4. Systemic blood pump. After oxygenation and temperature adjustment, blood reaches the systemic blood pump. This is the heart of the bypass machine. The pump generates cardiac output by propelling oxygenated blood into the arterial circulation. A flow meter continuously measures blood flow to ensure adequate systemic perfusion throughout the operation. Step 5. Arterial filter. Before returning blood to the patient, it passes through an arterial filter and bubble trap. This component removes the small air bubbles, blood clots, and particulate debris. This greatly reduces the risk of air embolism and systemic complications. Step 6. Return to the patient. Filtered oxygenated blood is returned to the patient through the systemic flow line, usually cannulated into the ascending aorta. At this stage, the bypass machine completely replaces the pumping function of the heart. All organs, including the brain, kidney, liver, and muscles, continue receiving oxygenated blood despite the heart being motionless. Aortic cross clamp. Notice the aortic cross clamp positioned on the ascending aorta. Its purpose is to isolate the heart from systemic circulation, prevent blood from entering the coronary arteries during surgery, and create a bloodless operative field. Once applied, coronary blood flow ceases until cardioplegia is administered. Cardioplegia delivery. One of the most important features of this schematic is the cardioplegia delivery system. Cardioplegia is a specialized potassium-rich solution used to intentionally stop the heart. The blood cardioplegia pumps mixes oxygenated blood with the cardioplegic solution. Pressure and temperature are continuously monitored to ensure safe delivery. The solution travels through the cardioplegia delivery line into the aortic root, where it enters the coronary arteries and arrests the myocardium. The goal of cardioplegia are to produce rapid cardiac arrest, reduced myocardial oxygen consumption, preserve ATP stores, and protect the myocardium from ischemic injury. Repeated doses are administered throughout surgery to maintain myocardial protection. Aortic root suction. Blood accumulating around the aortic root is removed using the aortic root suction. This improves visualization and minimizes blood loss. Cardiotomy suction. Blood that collects within the operative field is removed using cardiotomy suction rather than being discarded. This blood is directed into the cardiotomy reservoir. A filter removes debris before the blood is returned to the venous reservoir, reducing the need for donor blood transfusion. Left ventricular vent. The left ventricular vent removes blood and air accumulating inside the left ventricle. Its functions include preventing ventricular distension, reducing myocardial wall tension, improving surgical exposure, and preventing pulmonary edema. Keeping the ventricle decompressed also decreases myocardial oxygen demand. Suction and vent pumps. Several dedicated pumps are visible on the right side of the circuit. These independently control left ventricular venting, cardiotomy suction, surgical field suction, cardioplegia delivery. Independent control allows the perfusionist to precisely regulate each component during surgery. Safety features. Modern cardiopulmonary bypass incorporates multiple safety mechanisms. Venous reservoir with level sensor to prevent ear entrainment, arterial filter and bubble trap to eliminate emboli, flow meter to monitor systemic blood flow, pressure monitoring during cardioplegia delivery, temperature monitoring throughout the circuit, one-way valve to prevent reserve blood flow, and continuous surveillance by the perfusionist. These features make CPB highly reliable during complex cardiac procedures. Clinical applications. Cardiopulmonary bypass is routinely used in procedures such as coronary artery bypass grafting or CABG, aortic valve replacement, mitral valve repair or replacement, congenital heart surgery, aortic root and ascending aortic surgery, complex cardiac tumor excisions, and heart transplantation. To summarize, figure 56 illustrates the complete cardiopulmonary bypass circuit. Venous blood drains from the patients into the venous reservoir, passes through the oxygenator and heat exchanger. It is propelled by the systemic blood pump, filtered through the arterial filter, and returned to the body via the ascending aorta. During this time, the aortic cross clamp isolates the heart, while blood cardioplegia safely arrests and protects the myocardium. Additional components, including the left ventricular vent, cardiotomy suction, and aortic root suction, maintain a clear operative field, recover blood, and prevent ventricular distension. Understanding each component of this circuit is essential because successful cardiopulmonary bypass allows surgeons to perform complex intracardiac procedures while maintaining continuous systemic perfusion and protecting both the myocardium and vital organs. Thank you very much for attending this lecture. If you're new to the channel, don't forget to like and subscribe. See you in the next lectures.